straight into the topic. We know about the history of insulin to some extent. I'm sure you'll recognize the names Banting and McLeod, Banting and Best. They are the names which frequently come up when we talk of discovery of insulin. It's a very, very interesting story also. When you look into how medicine got evolved or how new drugs are discovered and how evidence-based medicine progresses, this is one of the classic stories to look into. It can also give you an insight into how credit wars and credit battles take place whenever there is an invention or a discovery. All in all, at the end of the day, it was one of the most important discoveries in the history of all of medicine, that is discovery of insulin. And about 100 years back, the newspapers screamed the headline that diabetes is on its way to cure. Unfortunately, after 100 years, we are still not curing diabetes, but we are managing it with their wonderful discovery. We know that insulin has got two chains, the A chain and the B chain. The A chain has got some 24 amino acids, 21 I think, and the B chain has got 30 amino acids. They are linked by sulfide bonds. And this is the regular insulin. This is the human insulin. It's all made of amino acids, as I said. And all the other insulins are modifications of this basic structure. You need not know the details of the structure, just know the basics of this. That somewhere or the other, some of the amino acids or some bond is just replaced and a new insulin is formed. A quiz for all of you. Which is the most powerful anti-diabetes drug available?
Request you to post your answers in the chat box of Q&A session.
Yeah, it's okay. They can just give it a thought. It is actually insulin. Insulin is the most powerful anti-diabetic drug available right now. Even after 100 years of discovery of insulin and so many other newer molecules coming in, nothing has replaced the original stuff. So on an average, insulin can decrease the HbA1c level from between 1.5 to 3.5% alone, when used alone. That's more than the sulfonylurea class of drugs, which can decrease the HbA1c from 1 to 2 points on an average. Again, it's an average. So some people might have no decrease at all, and some people can get an HbA1c of drop of even 4 or 5 points also in day-to-day practice. Some other reasonably powerful medicines of the oral antidiabetic drugs would be lifestyle is actually very, very important. When you combine lifestyle and metformin, the effect is almost as good as sulfonylureas or insulin, especially in the early stages of having detected with diabetes. So there are many mechanisms in which insulin will benefit. It is supposed to have cardioprotective, neuroprotective, and anti-apoptotic function. Exactly how it works in an anti-apoptotic role is still not known, but it is likely a chance association or or just a finding rather than the cause and effect over there. Of course, insulin lowers glucose. It reduces the end products of glycation. It reduces free radicals, which are caused because of that process, and eventually it reduces end organ damage, which is caused by all the toxic products of excessive glucose metabolism or faulty glucose metabolism. Insulin can be a vasodilator. It can also inhibit platelet function to some extent. So that's why the chances of MI might be lower, or cardiovascular disease might be lower in people who are on insulin. It provides rest to the beta cells of the pancreas so that they may have a chance of recuperating to an extent, and maybe their lifespan may be prolonged. Insulin is thought to have antithrombotic effect. That is again debated, but yes, there might be some antithrombotic effect. It may be an antioxidant and an anti-inflammatory also. So the indications of insulin, we all know, whenever the sugars are high, that's the indication for using insulin. Too high, that is. It is uncontrolled diabetes, or when oral anti-diabetic drugs are contraindicated or not tolerated. Just getting your attention to this terminology called OAD. We don't call them OHAs anymore. Not all drugs not all the tablets which are given for diabetes are hypoglycemic agents. Some of them are just anti-diabetic drugs like metformin or pioglitazone, which won't cause hypoglycemia. It's very, very rare for them to cause hypoglycemia. So now the terminology is OADs, that is oral anti-diabetic drugs. And OHAs, when you use that term, you mean specifically there is some sulfonylurea involved, usually, which can cause a hypoglycemia. To manage hyperglycemia in patients who are admitted into the hospital, there is nothing as fast and as controllable as insulin. In diabetic ketoacidosis or hyperosmolar non-ketotic states, it can be given. In some special populations like pregnancy, in which most of the tablets are contraindicated, you have to use insulin. In some diseases like CKD stage 4 and 5, again, where most of the tablets are out of question, insulin may come into the picture very early. In conditions where, like infection or sepsis, where the blood sugars will fluctuate very unpredictably, you can keep on managing, you can keep on measuring the blood sugars very frequently and titrate the insulin accordingly. And of course, stress hyperglycemia, which is a very temporary phase of hyperglycemia. It will come down later on when the cause of the stress is reduced. And to control that transient rise in blood sugars, insulin is probably the best bet. So what are insulin, human insulins, and what are insulin analogs? We have to know just a bit of difference in between them. Human insulins are exactly what is found in the human body. Only thing, they are made in factories now using bacterial DNA or yeast DNA. The human insulin gene is inserted into some kinds of bacteria or yeast. They produce the exact same human insulin, which is harvested. The best example of that is regular insulin. That is the usual common insulin which is produced by our body. Then there is NPH insulin. If anyone has time and if knows the answer, you can type the full form of NPH in the chat box. NPH insulin is a small modification which was made to regular insulin, by which the duration of action of regular insulin was increased from, say, about 6 to 8 hours to about 10 to 12 hours. So all the modifications to regular insulin were made with the intention of playing with the duration of time in which it will act and for how long it will act. The next type of human insulin would be the premixed human insulins. That is mixing regular insulins in various permutations and combinations. Like insulin 3070, which we know the commonest brand name is perhaps human insulin 3070 and Mixtard. And insulin 50/50, in which 50% will be regular insulin and 50% of the insulin will be NPH insulin. These are very easily available, accessible, very cheap, and available almost in every medical shop across the country. When we think of insulin analogs is what I mentioned earlier, that one of the amino acids in the A chain or B chain of the original insulin molecule is replaced by something else, some other amino acid, or some fatty acid chain is attached to the insulin molecule. So by doing that, the pharmacokinetics of the insulin might change, pharmacodynamics might change. That's how regular insulin starts becoming rapid-acting insulin. These insulins are called insulin lispro, insulin aspart, fast-acting insulin aspart, that is even more faster-acting, and insulin glulisine. So if regular insulin starts its action in about 15 to 30 minutes, reaches its peak in about 1 to 2 hours, maintains that peak for about 4 to 5 hours, and starts declining after 6 to 7 hours, the rapid-acting insulins like lispro, aspart, they will all start acting about 5 to 10 minutes, reach a peak between 30 to 60 minutes, maintain that peak for about 2 to 3 hours, maybe 4 hours, and have almost no action after 5 to 6 hours. So rapid-acting insulins start their action very fast and they end also very fast. Then similarly, there are longer-acting insulins. Long-acting in the sense they act longer than NPH insulin. NPH, as I said before, is expected to last about 10 to 12 hours. So longer-acting insulins usually will expect to last 16 to 24 hours. They are insulin glargine, insulin detamir, and insulin degludec. Now, insulin glargine and detamir are supposed to be 24-hour insulins. Technically, that's not very entirely correct. But yes, for practical purposes, we can say that they are once-a-day insulins and can be given, like expected to last at least 20 to 24 hours. Then insulin degludec is very special actually, because that's got a duration of action of about 30 to 35 hours at least. It can last to about 42 to 45 hours, in fact. So insulin degludec is so long acting that it can be given even on alternate days or whenever the patient feels so, at whichever time of the day the patient wants to take it. We'll come to that later, a bit later. Then there is co-formulation. The co-formulation is a mixture of including insulin degludec, which is about 70%, and insulin aspart, which is a rapid-acting insulin, which is about 30%. So there's a difference between pre-mixed insulin and a co-formulation insulin. Pre-mixed is, we just discussed, like Actrapid and human insulin 3070, they are all pre-mixed. That is, they are actually mixed in the solution. You have to mix it again. You have to take the vial or the cartridge again, and you have to roll it and all those things, so that you mix it well. The co-formulation is that the molecules are not really mixed with each other. They just coexist with each other. They don't interact, react, or anything with each other. They just exist in the same vial or cartridge. Then there are pre-mixed insulin analogs also, like insulin Lispro 25/75, which is like 25% of the rapid-acting insulin and 75% of the NPH insulin. Then there's insulin Lispro 50/50, Aspart 30/70, various kinds of permutations and combinations of short-acting insulins, rapid-acting insulins, intermediate-acting insulins like NPH, and long-acting insulins are available in the market. So I hope what I said so far is somewhat clear to you. Don't worry if it is not clear so far. Just keep on listening and it will become clearer when you hear it in different ways. The basal insulin. Now, what is a basal insulin? It gives a base for the body to maintain a steady insulin level. In other words, they are intermediate acting insulins or the longer acting insulins. The basal insulin, stereotypically, we call it NPH. That is NPH. That is insulin that controls the blood glucose level between meals and even overnight coverage. These control glucose in the fasting state. These are intermediate acting insulins like NPH and long acting insulin like glargine, detemir, degludec, etc. You can give basal insulins once a day for if it is a long acting insulin like glargine or detemir, and twice a day if it is NPH insulin, that is intermediate acting. Now, what are the bolus insulins? You give them as bolus shots whenever you need it or regularly before meal times. These are insulins that control blood glucose levels soon after the meals. That is the postprandial blood sugars. These include short-acting insulins and rapid-acting insulins. They are to be given always before a meal. Some insulins can be given just after a meal. The very rapid-acting insulins or fast-acting insulin aspart can be given just after a meal also. Now, pre-mixed insulin, like biphasics, they control fasting as well as postprandial blood sugars, depending on the concentration of the insulins within that solution. So down in the screen, there's a graph where this red line is rapid-acting insulin. As you see, this horizontal axis shows the duration of time, and the vertical axis shows how fast the insulin or how much the insulin will rise in the bloodstream after it is given. So as you see, the rapid-acting insulin will rise very fast and it will fall very fast and taper off to almost nothing after 6 to 8 hours. The regular-acting insulin is this one, the orange kind of the line. Short-acting insulin or regular insulin, that is Actrapid, what we commonly know as. It starts peaking. It will maintain this peak between 2 to 4 hours. After that, it starts declining. After 6 hours or so, again, it's not there in the system too much to be of effect. Intermediate acting insulin will start rising after 2 hours or so, maintain the peak from 4 to 8 hours, and then usually go off. Long acting insulins, they are called peakless insulins also. They don't have a real peak like these insulins have. See here, there's a peak, rapid acting insulin and short acting insulin, but long acting insulin is like a plateau. So it will maintain that level for 4 to 12 hours and then slowly start going off the system. Usually, most of this insulin will not be working much after 16 to 18 hours. Now, glargine is an exception. Glargine can actually work for about 24 hours or more. So this is the chart. This is a table which explains the same thing which I said just now. But you can just concentrate on this particular table, the frequency of administration of each insulin. We just discussed how much each insulin will act. So depending on the duration of action of the insulin, you can decide the frequency of how much you have to give it to the patient. So naturally, NPH insulin, it is intermediate acting insulin, will work for about 8 to 10 hours. So you can give it twice daily. Glargine, as we just saw, it can act for about 20 to 24 hours. So you can give it once daily. Detemir insulin, again a long-acting insulin, will work for about 16 to 18 hours. You can give it once a day. Sometimes you can give it twice a day. And degludec insulin, the latest, longest-acting insulin, which can act above 40 hours, can be comfortably given once a day. Coming to the bolus insulins, the regular insulins, you can give it 2 to 3 times a day, depending on the need of the patient. Same about aspart, lispro, blue lysine, all the rapid acting insulins, you can give it 2-3 times a day, depending on the PPPS patterns of the patient. If he's having a really large meal all the 3 times of the day, you may have to give it 3 times. If the patient is preferring to have one large meal a day and moderate or small meals at other times, you can probably skip the faster acting insulins. Maybe give it once or twice only in a day. So it is highly patient centered. Now, the premix insulin or the co-formulation. The co-formulations are mostly analog insulins, which are with the NPH or that kind of combination. So again, premix in human insulin 3070, it can be expected to last about 10 to 12 hours at least. You can give it once or twice a day. Remember, insulins which will have NPH in it will be usually cloudy. So you have to be very when the patient says that he doesn't know which insulin he's taking, but it's got some numbers on it like 30, 70, 50, 50. Obviously, you know what they're talking about. And if they say that it's a cloudy insulin, but taking only once a day, you can be pretty much sure that it has got some NPH in it. So co-formulations, most of them can be given 2 or 3 times a day. Now, this is what we were talking about previously. This is the most commonly well recognized co-formulations nowadays. The combination of insulin aspart and insulin degludec. The name is insulin insulin degludec aspart. I think the brand name is Rhizodec. So insulin degludec is a multi-hexamer. That is, it has got, okay, forget the physics of it. It's got just keep in mind that it's got six sides to that each insulin molecule. It forms a chain of hexamers. That is a multi-hexamer. Once it is under the skin, it will form a insulin degludec monomer. It will slowly dissociate into the bloodstream. Okay, and in the same co-formulation, there is an insulin aspart hexamer, which will dissociate rapidly when it is injected subcutaneously. So when insulin degludec aspart is given in a single injection, the fast-acting component will start its work immediately, while the ultra-long-acting insulin component will get dissociated very, very, very slowly. I'm not going to read details of it all. It's not needed right now, I think. Now, some practical considerations when you give insulin. You have to always be careful, especially in patients who are receiving higher doses of insulin like 30, 40, 45 and more units per day, that you prescribe the right kind of insulin along with the right kind of syringe also. There is a 40 unit syringe and there is a 100 unit syringe. So in 1 ml of insulin, there might be 40 units of that insulin, or in 1 ml of insulin in the vial or the cartridge, there might be 100 units of the insulin. So if you give a patient, if a patient takes a 40 ml, 40 unit per ml insulin and uses a 100 unit syringe to give himself insulin, the dose will not be what the doctor had prescribed. There is some calculation to be done when you change or interchange the syringes and the insulin which is given, which is far too complicated for the patient to consistently understand. Don't get into that risk. So whenever you are prescribing higher doses of insulin, it's better to give the 100 unit per ml kind of insulin along with a 100 unit 100 IU syringe. You have to be very clear to the patient about that. Now, patients also ask us, should we take a disposable pen or should we take a durable, like a reusable pen? Now, there's not much doubt in practitioner's mind and as well as the patient's mind that the pen is always the better device to use over a vial and a syringe. The pen is so easy to use. The only problem is the cost. There are so many choices of pens available in the market. If the cost is not an issue, the pen should always be preferred. Now, the durable pen, the reusable pen combines a reusable syringe and insulin container with disposable insulin cartridges. Okay, the durable pens can be reused by the patient and refilled at will. So it's very easy. The cost is lower in the long term. Disposable pen, they come preloaded with the insulin cartridge. And once empty, the device has to be discarded totally. The patient must buy another device. So for short-term use, a disposable pen is okay. If you're going to test the patient, like if you're going to give the patient a choice that you try insulin for a few days, if you like it, then we can shift to a durable pen or a reusable pen. In that kind of a situation, disposable pen can be used. But if you feel that the patient is motivated, willing, and will need insulin for a longer duration, it's always better to go for a reusable pen, durable pen. So pen devices are always better in comparison to vial and syringe because they're easier to administer, because the pain is almost nil nowadays with good pens. The adherence rate of patients with insulin is very high. Because the dosing is more accurate through pens, the glycemic control is better, which has its own benefits like less chances of hospitalization, lower chance of hypoglycemia. Sometimes less insulin dose is needed because wastage is lesser. It's safer to administer through a pen rather than through a syringe and the vial, where if the needle breaks, it's more of a difficult job pulling it out. And most of the patients tend to choose pens once they are started on it over vials and syringes. So insulins can be used for short term in newly detected severe hyperglycemia. Later on, they can be shifted to tablets in people who are initiated on insulin for a short duration or for short-term hospitalizations. In pregnancy, insulin can be used. Elderly patients, insulin is a good choice. Patients with visual disturbances or problems with infirm hands, their hands will keep on shaking, their body will keep on shaking. They can't draw the insulin from the vial into the syringe. Those kind of people, the pen is always a better device. Patients undergoing surgeries also, it's easier for them to handle a pen in the bed compared to a vial and a syringe. So pens have a lot of practical advantages.